Hello and welcome to Season 2, Episode 81 of the Physician Assistant Exam Review Podcast. Today we're going to move through coagulation factor disorders. My name is Brian Wallace. I'm the host and creator here at Physician Assistant Exam Review, and I am so excited to have you on board today. This has been a little bit of a challenging topic with hematology. I know it's just 3% of the PANCE and the PAN-RE, but some of the topics are a little more complicated, a little more difficult to hold in your head, like lymphoma, like leukemia, like the coagulation cascade, all these things. So it's a little bit difficult, even though it is a small portion of the exam. But I think you can hold on to a lot of this stuff. I think you really can. But what I like to do is be able to organize the information so that you can place in the details as you get better, rather than just dumping all the details at you and hoping you hold on to something. I think having that 30,000 foot view, that grounding, that idea of where everything belongs and the order it goes in, and organizing the contents is, I guess, what I provide, as opposed to the real deep details on each topic. I think you get tons of that from your professors, tons of that in other publications. And I think what I can provide for you is that connection to the material, that understanding, that deeper understanding of how it works together. So anyway, we're going to move on today to coagulation factor disorders as we move through hematology and some issues with coagulation. I know last week I used the words agonist and antagonist interchangeably, and we'll get to clearing that up as we go through our priming questions today. So for today, let's go ahead and get started with our priming questions. How does warfarin thin the blood? We're just going to jump right back to last session. How does warfarin thin the blood? Do you remember from our last discussion? Well, it's a vitamin K antagonist, and vitamin K is hold on, I'm not supposed to give those away to the end. I've been doing that a little bit lately. All right, so what is one thing von Willebrand's factor does to increase clotting? We're going to go over this again today because it's a important detail. What is one thing von Willebrand's factor does to increase clotting? And then another question from last week. Factor 1A is the tough, stringy endpoint of the clotting cascade. What is its other name? Factor 1A is the tough, stringy endpoint of the clotting cascade. What is its other name? I should really not have the answers to these in my notes in front of me at this point. What would the normal range for platelets be? What would the normal range for platelets be? All right, let's move on to our coagulation factor disorders. So number one is going to be von Willebrand disease. Von Willebrand disease is the number one most commonly inherited clotting disorder, right? So it's a relative, we see it a lot in the operating room. By a lot, I mean every once in a while. But von Willebrand disease definitely comes up. It is a spectrum of low production to low production of poorly functioning von Willebrand's factors. And we talked about von Willebrand's factor a little bit in the last session. There are two major functions for von Willebrand's factor. The first is it helps platelets to stick together. That's a major, major point. It helps platelets to stick together. If you remember, we talked about when a blood vessel is damaged and the subendothelial collagen comes in contact with blood, the platelets stick to that collagen, and the von Willebrand's factor really help it to stick to that collagen and help the platelets to stick to each other. So that's a major point. The other important point that we didn't cover so much in the last session was that it also binds to and maintains factor 8. In blood circulation. Factor 8 would normally break down pretty quickly in the bloodstream if it's not bound to von Willebrand's factor. So what it does is it maintains another clotting factor in the system. Von Willebrand, just as a side note, was the pediatrician who first described the disease in 1926. How do these people come into the office? They have easy bruisability, frequent nosebleeds, bleeding from the gums, heavy menstrual periods, that sort of thing. Labs and studies, PTI-NR is usually normal. PTT can be prolonged. You can do a total plasma von Willebrand's factor antigen test and measure the serum antigens. You can also do a von Willebrand's factor functioning test and a plasma factor 8 serum level. And again, we talked about how factor 8 binds to von Willebrand's factor, and that helps to maintain it. So you'll see a drop in factor 8 in a von Willebrand's disease. And treatment Desmopressin is a synthetic antidiuretic hormone, which is vasopressin, right? So that'll stimulate the release of von Willebrand's factor. So it'll stimulate some extra release. In a patient who does not have that severe case, desmopressin will be enough to increase the circulating von Willebrand's factor and help them to solve this problem. In someone with a more severe case, this may or may not be all that helpful. You can do a factor VIII concentrate. You can give a patient that, especially something like before surgery or in a trauma situation, and then platelet concentrates may also be given similarly. Hemophilia A and B is next. Hemophilia A is a deficiency in factor VIII. Hemophilia B is a deficiency in factor IX. Hemophilia B is also known as Christmas disease. Stephen Christmas was the first patient diagnosed with the disease in 1953. Both are X-linked recessive, therefore males only need to inherit one mutant gene, whereas females need to inherit one from each parent. About 30% of patients have no family history of hemophilia. Many different mutations can cause hemophilia, so there's a wide range of severity, just like our von Willebrand's disease. I didn't go into a lot of detail, but it can get broken up into many subtypes. And that all depends on when the mutation occurs, where it occurs. If you remember, we had our discussion of lymphoma, is very similar. It depends on when those issues happen and where they lie. So these are sort of bigger buckets, and they can be broken down into much smaller categories to be more efficiently treated. But for our purposes, again, we're going to stay at a little bit higher level. Clinical presentation obviously is bleeding again, just like we had for the other ones, prolonged bleeding time from minor injuries. But here we can get some muscle and joint pain secondary to bleeding into joints. Labs and studies, PTI-INR are normal. Bleeding time is normal. PTT can be prolonged. And a low factor VIII and low factor IX are diagnostic tests. One thing I didn't mention for von Willebrand's disease and also for hemophilia A and B is they'll have a normal platelet count. So bleeding with a normal platelet count. Treatment here is going to be the mainstay of treatment is going to be replace the missing factors, right? So we can give into the serum the missing factors when necessary. And that depends on how the disease is affecting the patient. So if you have someone with very severe disease, they may need to get those factor concentrates routinely. If you have someone who with moderate or mild disease, they may just need it before a dental procedure, before surgery. In minor cases, with patients with minor symptoms, you can also use desmopressin because that will help to increase the von Willebrand's factor, which will then allow for the increase in circulating factor VIII, right? Because that was the protein that helps to keep factor VIII in circulation. Another hemophilia you could talk about is hemophilia C, which primarily occurs in Ashkenazi Jewish population. Here, there's a deficiency in the coagulation factor 11. These patients do not have bleeding in the joints. In fact, this is not as severe as A or B in most cases, and they do not require treatment in most cases. They do have prolonged bleeding time, frequent nosebleeds, heavy menstrual bleeding, and there is not a test to isolate factor 11 deficiency. So this is sort of a diagnosis by exclusion. Again, normal platelets, that kind of thing, and you have normal levels of factor 8 and 9, and you sort of wind up here. Treatment, again, usually not really much treatment necessary for this, but you can use fresh frozen plasma, platelets, and desmopressin to help with the symptoms here. We're going to talk a little bit about platelet dysfunction. So normal platelet count is between 150,000 and 450,000. Those are numbers you should definitely know, between 150,000 and 450,000. Thrombocytopenia is defined as platelet count below 50,000. At that point is when you really may need to consider some emergency treatment that's below 50,000. A couple terms we need to know for physical exam: petechiae. These are red or purple discolorations of the skin that do not blanch. These are tiny. This is 1 to 3 millimeters in size, really small. Purpura are more like bigger bruises. These are red-purple discolorations of the skin, again, that do not blanch. These are 3 to 10 millimeters in size. Now, to get low platelets, you can have a couple of issues. You can have poor production. You can have increased destruction or use of the platelets. Or you can have dilution. Right, so that'll all lower our circulating average volumes. We can have poor production, so we're not making enough platelets or not making functional platelets. We can have increased destruction of the platelets. So if the spleen is sequestering platelets in some of these diseases, what we'll do is we'll actually remove the spleen to stop it from taking out platelets. Or we can have increased use of the platelets, right? If we overuse them, if we use them all up, then we'll have low circulating platelets, right? That makes sense. Megathrombocytes are immature platelets recently released from the bone marrow. That's another term we need for this section, megathrombocytes. All right, and then the one kind of disease state we're going to talk about here is idiopathic thrombocytopenic purpura. Idiopathic thrombocytopenic purpura, ITP. We'll get to some others and use some of these other petechiae and purpura also in the next session. But for this session, we're just going to stick with this one to kind of keep it as simple and straightforward as we can. So ITP. This is an autoimmune disease with antiplatelet antibodies. So here's a major problem, right? You're making antibodies against your platelets. This acute form tends to happen in kids following an upper respiratory infection. There's a chronic form that tends to happen more in adults. And in the majority of these patients, you can test for these antiplatelet antibodies. I think it was like 60 or 70% of people will demonstrate these antibodies, but not everybody. So it's a little bit of a diagnosis by exclusion. Clinical presentation, we get a sudden onset of petechiae and purpura found on mucous membranes and on the skin. Severe nosebleeds, excessive menstrual bleeding, and noticeably long bleeding times. Here we'll have a low platelet count with no apparent reason for it. And on a peripheral blood smear, we'll show those megathrombocytes. This is a diagnosis of exclusion, so a complete hematological workup may be necessary. And like we said, you may find those antiplatelet antibodies in the lab. Treatments, we're going to avoid aspirin and NSAIDs. Really, that's going to be for everybody here. We're going to avoid aspirin and NSAIDs. Typically, no treatment is necessary for either acute or chronic disease. However, if you need to, steroids are a good place to start if we're talking about autoimmune disease. A splenectomy may be necessary to reduce platelet destruction. But obviously, the surgery here has risk. If we have a patient who has issue with bleeding and then we're going to take their spleen out, that surgery has some obvious risk to it. And we can do a platelet transfusion in the case of surgery or severe trauma. All right, and that will end our coagulation factor disorders and our platelet dysfunction issues. In the next show, we're going to be talking about hypercoagulable states, and that gets, again, a little more complicated. So we go from our bleeding too much to clotting too much, and we bounce back and forth. And that's really the balance with the coagulation cascade and in hematology in general. It's keeping the blood flowing but not leaving your body. That's sort of the complicated part. So let's get into our study tip for today. Our study tip for today is going to be about motivation. Here's the deal. If you tell yourself that a specific topic or a specific piece of information or a specific section of the PANCE is not relevant or important to you, your brain will dismiss it. If you say to yourself, this doesn't matter, why am I doing this? Your brain will file all that information under the unimportant section, right? And you will forget it. I know this from excessive study, but I also know it from my own life, right? When for years I said, listen, I'm not going to learn leukemia and lymphoma. I'm just not going to bother. It's not that important for what I'm doing. I don't need to know it. And so as I went through it, I found it was hard to remember. So then I didn't bother to learn it. And a big part of that was my decision that it was irrelevant to what I was going to be doing, that it was hard, so I dismissed it outright. I see a lot of people do that on a lot of topics, on a lot of information. A lot of students say, well, when am I going to use this? I don't need to know this. Well, when you do that, you've given your brain specific instructions not to learn it. And the problem is you don't necessarily get to make that choice. It's going to be on your test. It's going to be on your exams. So you need to, what's really helpful is if you can convince yourself to be engaged and find a reason why it's important to know the material, even if you don't necessarily think it's relevant, if you can convince yourself that it is relevant, it'll be so much easier to remember rather than dismissing it and convincing yourself it's irrelevant and hiding it away. Because it does make a difference. It makes a difference in your focus. It makes a difference in how your brain categorizes the information. So your motivation for learning is a huge factor. So even if you don't think that you're going to use a particular piece of information. Come up with a reason why it's relevant to you. Come up with a reason why, even if that's just that it's going to be on the test. And convince your brain to hold on to the information rather than dismissing it outright and wondering why you forget it later. Well, you've told your brain to forget it. You've told your brain this doesn't matter. Glance over it. Your brain spends its entire day figuring out what's relevant, what's important, what's not important, right? There's billions of pieces of data that come flying at you constantly. What you see, what you hear, what you smell, what people are talking about around you, right? If you're in a room full of people, you can hear everyone talking, but you don't actually filter into any specific conversations. You control where that focus is. I hope that makes sense. So you can focus on one conversation, you can hear it and retain it. You can't focus on them all at once. So your brain automatically dismisses those conversations around you. It dismisses a lot of data around you that isn't either dangerous or important. And that's what you want to do here. You want to come up with a way to focus even when it doesn't feel like it matters, and to convince yourself that focus is the most important thing. All right, let's get into our priming questions. Hopefully you can answer these pretty easily. How does warfarin thin the blood? Again, we said at the beginning, I made the mistake once again of giving away the answer, which is it's a vitamin K antagonist. Vitamin K is necessary for the production of clotting factors. What is one thing von Willebrand's factor does to increase clotting? Well, it increases binding between platelets and subendothelial collagen. We talked about that. Factor 1, or you could also have said that it binds to and maintains factor 8 in circulation. Factor 1A is the tough stringy endpoint of the clotting cascade. What is the other name for that? The other name is fibrin. It's fibrin. All right, that's the all-important end to our clotting cascade. What would the normal range for platelets be? 150,000 to 450,000. And I'm just going to throw in here, what was thrombocytopenia? What was the point where we started to get really concerned? That's 50,000. All right, well, we've done a lot of good work here. We've done a lot. We've covered a lot in the last 2 episodes. The next one will be no different. And it's tough to maintain all these. I don't want to I want to give you the benefit of the doubt, but I want you to also understand that not everybody gets these on the first pass. You know, a lot of people are dismissive, like, oh, this is easy, that's easy, I got this, I got that. And there are some sections that are like that, and everyone learns in their own way. So some people get one thing easier than another thing. Some people see one topic easier than another topic. But in the end, if we're all different, right? So some of these things are a little bit harder for each of us. So if you find yourself struggling in this area, don't worry about it. Everybody struggles in some area. Keep plodding along, keep that 30,000 foot view, and then just keep adding in the details until, as it makes sense, you add in more details. And you'll have plenty by the time you get to your PANCE. You get plenty by the time you get into practice. I know that you got this.